All right, let's get right into it. Your next patient has a new heart, a new liver, or maybe a new kidney. They're not coming in for the transplant, that's done. They're coming to you for something else entirely. So what are the critical life or death things you have to know to keep them safe? That's what we're breaking down today. A deep dive into the therapeutic problems of organ transplantation that you need to know both for your exams and for your practice. So, let's start with a number, 5,000. What is that? Well, in the UK alone, that's roughly how many people are on the waiting list for a kidney transplant right now. And that really puts it into perspective, doesn't it? These are not rare, once-in-a-career patients anymore. This is becoming more and more common. You are going to encounter these patients, and you need to be ready. So here's our game plan for this explainer. We're going to start with the big picture issues, the universal challenges that every single transplant patient faces. Then we'll do a deep dive into the big three, the liver, the kidney, and the heart. And we'll wrap it all up with the key takeaways for you. Let's get started. Okay, first up, the universal challenges. These are the problems that you need to have in your mind no matter which organ we're talking about. And it really all starts with the powerful, life-saving drugs that make transplantation possible in the first place. Here is the fundamental trade-off of organ transplantation. Every single recipient is on lifelong immunosuppression. And these drugs, while they are absolutely essential to stop the body from rejecting the new organ, they also open up a Pandora's box of other major issues. We're talking about a constant, delicate balancing act between saving the organ and protecting the patient from everything else. Now, this diagram is a really great way to visualize how these different drugs work. You can see they all attack the immune response, but they do it at different points. See the calcineurin inhibitors like tacrolimus? They go right after T-cell activation, a critical step in rejection. And then you have the steroids, which are kind of like a sledgehammer. They affect the transcription of inflammatory genes directly. That's why they're so potent, and also why they come with so many side effects. So, let's break down these classes. I find it helpful to think of them in terms of their roles. Steroids, they're the firefighters. You use them acutely, right around the time of surgery, to put out the immediate flames of rejection. Calcineurin inhibitors, on the other hand, are the long-term security guards. They're the cornerstone of day-to-day immunosuppression. Then you've got your specialists, like the antimetabolites and biologicals, which target very specific pathways in the immune system. Now, this brings us to one of the most feared complications, post-transplant lymphoproliferative disorder, or PTLD. This is a real nightmare scenario. Essentially, we suppress the immune system so heavily that a very common virus, Epstein-Barr, can just run rampant. This leads to uncontrolled B-cell growth, which is a type of lymphoma. It's a direct, life-threatening consequence of the drugs we're using, and it's something you have to be vigilant for, especially in that first year. All right, now for the main event, the liver transplant. Honestly, this is where you will see some of the most dramatic and challenging anesthesia of your entire career. We're talking about the potential for just massive blood loss, wild physiological swings, and a patient who is right on the edge. A liver transplant really unfolds like a three-act play, and each act is its own high-stakes drama. Act 1, the dissection. Mobilizing the old cirrhotic liver means dealing with portal hypertension, and the risk of catastrophic bleeding is incredibly high. Act 2, the anhepatic phase. For a period of time, there is no liver in the body. You're walking a metabolic tightrope without a safety net. And finally, Act 3, reperfusion. The new liver gets blood flow, and this is a moment of truth that can lead to immediate cardiovascular collapse. Now, the surgical technique makes a massive difference for you as the anesthetist. With the classical technique, they have to cross-clamp the IVC, the main vein returning blood to the heart. You can imagine what that does to venous return. It plummets. This often requires veno-venous bypass just to keep the patient stable. The newer piggyback technique, however, preserves that IVC. It's generally much more hemodynamically stable, and that makes your life a whole lot easier. This is the moment that can make your own heart stop. Post-reperfusion syndrome. The second the clamps come off the new liver, a flood of cold, acidic, potassium-rich fluid hits the patient's heart. And they can just collapse. We're talking a massive, sustained drop in blood pressure that is associated with much higher mortality. It's a true anesthetic emergency waiting to happen. The key here isn't to react, it's to anticipate. Surviving PRS is all about preparation. First, you have to communicate clearly with the surgical team before those clamps come off. Second, you optimize the patient as much as you can beforehand. Correct the acidosis, warm them up. And third, have your rescue drugs drawn up and literally in your hand. That means calcium to protect the heart from the potassium surge, and a vasopressor like metoreminol or even diluted adrenaline ready to go. Okay, let's shift gears now and talk about the kidney transplant. This is a totally different ballgame. The surgery itself is usually much less dramatic than a liver. The real anesthetic challenge here comes from the patient's extensive medical history. We're talking about someone with years of chronic kidney disease and all the problems that go along with it. This table is a classic exam topic, and for very good reason. The medications that are keeping your kidney patient alive at home can become a recipe for disaster under anesthesia. You see here, their ACE inhibitor can lead to profound hypotension that just doesn't respond to your usual treatments. Their diuretics can cause wild electrolyte swings. And that spironolactone? It's just adding to the risk of hyperkalemia. You have to know these interactions cold. So once the surgery is over, what's the number one thing you're worried about? That new kidney clotting off. Primary vein thrombosis can cause the graft to fail within 48 hours. You have to remember, this is a low-flow organ. If the patient's blood pressure drops or if they get dehydrated, that delicate new graft can thrombose and die. Your job is to keep that kidney happy, and that means keeping it well perfused at all times. And now for the heart. This is where things get physiologically fascinating. A transplanted heart is a denervated heart. It has been completely severed from its autonomic nerve supply. It's on its own. And what that means is that all the normal rules you learned about cardiac pharmacology, well, you can pretty much throw them out the window. So here it is, the classic exam question. Your patient with a transplanted heart is profoundly bradycardic, and their blood pressure is tanking. You reach for atropine. What happens? I mean, really think about it. What is the mechanism of atropine, and what is physiologically different about this heart? And the answer is absolutely nothing. Atropine will have zero effect. Why? Because it works by blocking the vagus nerve, and this heart doesn't have a vagal nerve connection anymore. It's been cut. The same goes for indirect agents like ephedrine that rely on nerve endings that are gone. You have to go straight to direct-acting agents, drugs like adrenaline, noradrenaline, or isoprenaline that will directly stimulate the heart muscle. It's the only thing that's going to work. Now let's talk about a long-term silent killer, coronary allograft vasculopathy, or CAV. This is an incredibly aggressive, diffuse form of coronary artery disease that attacks the new heart's blood vessels. But here's the really scary part. Because the heart is denervated, the patient doesn't get angina. They don't feel chest pain. They could be having a massive heart attack and be completely asymptomatic. It's why they need to be monitored so closely. So we've gone through 3 incredibly complex scenarios. Let's boil it all down. What is the bottom line? What are the absolute key takeaways you need to have in your head when you're faced with a transplant patient? It really comes down to these principles. Know your immunosuppressants inside and out. For a liver transplant, just be prepared for a major hemorrhage. For a kidney patient, be deeply suspicious of their daily medications. For the heart, remember its unique altered pharmacology. And perhaps most importantly, if your transplant patient is deteriorating for any reason, your first thought should always be a problem with the graft. And that leaves us with this final critical question that you should always ask yourself. When things are going wrong, is the problem with the patient, or is the problem with the part of the patient that isn't their own? The answer to that question will completely change your approach and could be the difference between a good outcome and a disaster. All the information we covered in this explainer was based on the 2024 article, Therapeutic Problems Associated with Organ Transplantation, which was published in Continuing Education in Anesthesia, Critical Care, and Pain. It's a fantastic resource if you want to dig even deeper. Thanks for joining me.